one thing that's new is the recent ACR Vasculitis Foundation guidelines. There have been pre-existing guidelines for Kawasaki disease that are excellent and have been done for years by the American Heart Association. But for some more complicated cases where rheumatologists might see these patients, there were some additional recommendations. And some of these additional recommendations are based on recent research. So one of those recommendations is that for patients that appear to be higher risk, and that's a difficult question because we don't know exactly how to define high risk, but one thing that we do know is that patients who are, again, very young at extreme of age, so under 6 months, or patients who have already presented with aneurysms in the first 7 to 10 days when they are first seen, are more at higher risk of either being refractory or having aneurysms that don't want to go away. Those patients can get a dose of steroids with their IVIG and a sort of a course of steroids over 10 to 15 days. And that it apparently, and there's still some studies going on, but appears to decrease the rate of aneurysms down the line. The secondly is we talked about the refractory Kawasaki disease, where you might need a repeat dose of IVIG. And that in our guidelines has been sort of validated as an okay thing to do, but sometimes in some people, repeat doses of IVIG can lead to transient breaking down of red blood cells by an immune mechanism. And so in some patients, use of other kinds of repeat or secondary line therapies is more recommended. Third is use of high dose aspirin. So it has been very much part of tradition that when patients with Kawasaki disease are first diagnosed, they're started on very high dose aspirin. And that's sort of a holdover from the very, very, and I should say I'm getting up there too. So the ancient days when Kawasaki went before IVIG, and in those days, the only therapy was aspirin. So high dose of aspirin were used, but there's really no evidence that high or low dose of aspirin, there's no difference between that dose choice, although using aspirin of some dose is important. So the guidelines suggest that any dose, whether it is low or high, could be used. IVIG remains the central tool for Kawasaki disease in our guidelines. And then, as I mentioned, in the refractory cases, using biologic therapies can be used